Good morning, Keene and Bells Falls, and welcome to the feed. Today we're here with another Springfield Hospital Spotlight. We have Nicole Young, the Director of Perioperative Services, and we have Mary Ann Bonneville, the Head Nurse for Endoscopy. Welcome.
Thanks for having us.
So, Nicole, tell me a little bit about yourself and what it means to be the Director of Perioperative Services, and what is Perioperative Services?
I started in the emergency room at Springfield Hospital about 15 years ago.
Wow.
Been there for quite a while. I was recruited by Kathy Howland. She actually called me and asked me to come join them. Started there, had a great time in the ED, learned a lot, got to see a lot, meet a lot of people. Shortly after having my last child, one of the employees from Perioperative Services came over and said the hours are great. It's a great family life job. And so I
Probably
jumped.
a little less stress, too.
A little less stress. The hours were better.
Yeah.
And so I jumped ship and I joined Perioperative Services. I started working in the pre-op unit and the recovery unit. We had, rather quickly, a lot of staff changes. We had a lot of people retire. Some people quit. We eventually joined forces with endoscopy because they weren't originally a part of the immediate staffing group, but they had some staffing challenges as well. So we kind of figured it all out, worked through it, got everybody trained. And then our nurse manager, she ended up giving her notice, and they asked me to kind of take over and run with it. So here I am, been doing it for like 5-7 years now. It's been quite a while. Time's flown.
Yeah.
A lot of change.
I was going to say, you've been through a lot.
We have been through a lot.
It's been a lot in 5 to 7 years.
It really has been. We've gone through a lot of staff, a lot of providers, but I currently oversee the endoscopy unit. I oversee the pre-op unit, the recovery unit, the OR itself, the sterile processing unit, and then I've also added the infusion clinic, which is upstairs on level C.
Yes.
I took over for them probably 4 years ago. So,
Great.
yeah.
And Mary Ann, how long have you been at Springfield Hospital, and what brought you to Springfield Hospital?
Closeness to home.
There you go. Sometimes that's
It's
the best
8
part.
miles door to door, so it's an easy commute. I've been there 26 years. It'll be 27 years in August that I'll be there. Started out as an LNA on the inpatient care unit, worked my way up to my RN, and with all the support from all the staff, great people that work there, I ended up down in the endoscopy unit about 11 years ago, and been there ever since. I love what I do. I like that we have a good group of people that work there. Everybody helps everybody else. It's like a big family.
Nice. So you mentioned that as we all know, there's been a lot of changes, and you've seen some staff changes. And I know, probably a few months ago, we had Dr. Bennett and Dr. Lewis on, who are now your full-time surgeons. Are you seeing a difference now, the fact that you have, like, I think previously you're using locums, which means kind of like per diem people, like they only come in for like a day? Is that how locums work? Or I'm not super.
We were fortunate. Our locums would come for a group of time,
okay.
They were there for a little bit, but it was rotating locums, so you never were certain who you were going to have. The locums were great. They did the job. They helped us get through. We have been fortunate with the addition of Dr. Lewis and Dr. Bennett that we can build relationships with the patients. It works out great because they can see them in the office before their endoscopy procedures. They do the procedure, and then they do their follow-up. So they're not seeing 3 different people for something that
That's huge.
It's been great.
As a patient, that would be very disconcerting to not have that familiar face each time I went, to have to re-explain, kind of re-explain yourself to the doctor.
Along with the staff as well, because with the providers, the surgeons, they all kind of practice differently. So every time you had a locum, you were having to learn their practice, even if it was only for a couple of days. So we've been able to work with Dr. Lewis and Dr. Bennett, get them the supplies that they need, learn how they work, be able to support them in the endoscopy suite, and kind of just make things really better for the patients and the staff.
Yeah. And you've been seeing an uptick in
We have.
Yeah.
It's been great. It took us, I don't know, a little bit, but now that the providers in the area and the patients know that we have full-time surgeons, we've been able to really build our patient load both in the practice, which overflows over to the endoscopy suite in the operating room.
I think that makes a huge difference. So Mary Ann, endoscopy is both endoscopy and colonoscopy, correct? I always get that confused. I know that endoscopy technically is the upper
Endo is
haven't-
inside.
in endo.
So,
and then the colon.
so endo means you're going in. So you're going. So and then
Oh, so in
endoscopy.
general.
So
Okay.
an EGD is a long word that I can't pronounce.
Okay.
So I'm not even going to try.
Perfect.
and then the colonoscopies, and we, it. They are easy cases to have done. The patients all come in nervous, and we have a good group of people that we can calm them down, and they are more relaxed by the time they leave because we just talk to them. We talk to them like they're a normal person. We encourage them to come and see us, and when they come in and their blood pressures are high, and you talk to them and you just say, well, the hard part was yesterday, today's going to be easy. You're going to sleep through your procedure, and when you wake up, you're going to have had the best nap you've had in your last 20 years because you do get a good 20-minute nap. And they all wake up happy, they leave happy. And so we're very lucky that we have them coming in, encourage more people to come and see us.
So in that vein, let's talk about the whole process. So if you need to have, and I know that I couldn't quite get you in March. I know that March was colorectal
Cancer
awareness, and that is the third most common cancer in the country. So y'all should be paying attention, folks. So talk us through, because I think either procedure, the colonoscopy or the endoscopy, is mildly scary thinking. But talk us through, like, you book your appointment and you get your procedure, like they tell you exactly what you have to do to prep, correct?
Yep. So it starts with the offices hopefully sending the slips to the general surgeon office, and then they get booked through the general surgery office, and then once they're booked and they have their appointments times, then they get called by one of the nurses and go over some pre-op stuff just to make sure we have everything that we need. They do get their instructions emailed to them or sent to them by mail, so they have all of that. And if you have questions, they can call, or when we call them, they can ask us. But once they come into our department, they come in, we talk to them, they get changed into their gown, they get into the bed, and we ask them the similar questions just to find out what's going on, find out why they're there, why they're coming in for their procedure. Sometimes it's diagnostic, sometimes it's just a routine screening. Once they're in the room and we have them all ready, we do their vital signs, get an IV, ask them questions, and we explain to them what they're going to be getting for medications. They get, basically, for us, we give them or anesthesia gives them propofol. It's a wonderful medication, an easy one to go to sleep on, easy one to wake up from. So the procedure itself takes about 30 minutes, and then they're awake and they've had the best nap.
You're right, and you're absolutely right. The actual procedure is nothing compared to the day before.
The day before is not a pleasant day, but it's something that has to, because you have to have a clean colon. And visualizing, to me, is better than not. It's like seeing is believing. Like, if you see something, then you believe it. So Cologuard is a good option for people who will not come in and see us, but visualization is where you get those polyps out quicker, which are the things that would potentially turn into colon cancer.
And and with the Cologuard, you're not apt to find the polyps.
They just detect something that could be a polyp.
And you have to do a colonoscopy anyway,
if
right?
they come
so
back,
you have to do two. You have to go through two procedures.
If they
versus
come
one.
back positive, then yes, they have to still do a colonoscopy because you got to visualize. But we've also had false negatives come in too. So it's visualization to me is what you should have done.
Yeah, no, I agree with you. And so the prep the day before, what is it's Miralax?
Yeah, we
correct?
use the Miralax prep. So it's 64 ounces of liquid mixed with Miralax, and people can start as early during the day as they want. The instructions say to start at certain times, but you can start as early in the day and drink it as fast or as slow as you want, as long as you get it in within that day. Because then some people, they get sick or they start feeling like they're going to be sick. So when they call, we just tell them to slow down. Just slow down your drinking, drink something else. Because you should drink that 64 ounces of Marilex along with 64 ounces of other clear liquids on top of that, because the more you can drink, the better. They do the Ducalox tablets too to help get things moving prior to starting the Marilex.
Yeah, no, I think that's great advice. What you said about you can start as early. I learned the hard way one time. I followed the directions to a T because I'm a rule follower, shocking. And the next time I did it, I'm like, I think I'm just going to start like a little bit earlier. Because once everything's done, right? So the earlier you start and get it over with, then it's, it's much more. And it's really not that bad, folks. It really isn't. And I did find the last one I had done was the first time I think that you used propofol. Had you used something different in the previous?
Well, yes, we've been using propofol for over 10 years. It was fentanyl and Versed. And with fentanyl and Versed, people took a lot longer to wake up. And then you felt more like you are more fuzzy. You feel like you've been more drugged during the day afterward. Was with propofol. You might feel a little fuzzy for a couple hours after you're done, but you're more alert and aware of what's going on when you wake up and you leave the department.
Oh, and I was completely out. Like I remember the anesthesiologist, like, I don't doing, okay, I'm going to give you, and then next thing you know, like, can you wake up now? I'm like, what? So it's like, you don't even know what's going on. That's like the beauty of it. And I didn't really even realize it's only a half hour.
Yeah, it's like the best 20-minute nap.
That's awesome. So hopefully we've lessened some fears for some folks. Anything that you wanted to add, Nicole, to that?
No, I would agree. I mean, we got a great little process at our hospital. We're unique a little bit in that our patients are prepped, procedured, and recovered in the same room.
I like that.
Unlike bigger facilities where you get prepped in one room, then you have your procedure, and then you're discharged from either there or somewhere else. Once you come in, you get all settled in, your stuff stays in there, you have the same team. We're also fortunate that we have the 2 rooms, but we have 2 teams in a sense that you have one nurse the whole time and you have one scope assist. So the CRNA and then the surgeon bounce rooms.
Nice.
So it works out good. You get to really know your
I think that's
patient.
important. I recently took a friend to another bigger hospital in the area, and it really felt like an assembly line.
Yes.
I was actually given a pager
Yep.
to let me know when that person would be ready, and we had to find a whole different location from where the drop-off was and to where the pickup was. It just felt assembly line-ish. Fine if that's like your jam, but my jam is more, I like that, the small town,
personable.
the personal feel,
Yep.
that you have someone like the same person. For me, it's like your stuff stays with you,
Yep.
so like, because you're probably going to have your purse or your phone or all that kind of stuff. And that could, I just think that's important. That's cool.
Our surgeons also come in and see the patients at the end of the procedure before they're discharged. We're fortunate in that because we are so small, before they go into the next procedure, they come in, they let you know what they found, they go over any possible concerns. If we have to, we'll bring family members in to help have that conversation if we think it might be a little awkward conversation or not a pleasant one. But having that flexibility to really stay there, get to know your team, not have to worry about moving, going through the cold hallways, it's very nice.
Yeah, no, and I think isn't like the colon cancer like has very few symptoms, so you could have no idea that you have something going on.
Sometimes by the time you have symptoms, you're pretty advanced, you're pretty far
Yeah.
into it, unfortunately.
Yeah, most of the symptoms when people end up getting diagnosed with a colon cancer as rectal bleeding, and sometimes people just refer that to us being hemorrhoidal bleeding, which you can't write that off because we had someone come in a few years ago who had complained about rectal bleeding and just figured it was her hemorrhoids, and she came in and she had full-fledged colon cancer. That was, I guess it was staged at stage 4. They did the surgery and she survived like 6 months after because it had metastasized to other parts of her body. So, if you're having rectal bleeding, don't pass it off as just being hemorrhoids. Get a colonoscopy or at least go see your primary care provider and take the next steps, because colon cancer is 100% curable. Well, close to 100% curable. Nothing's 100%,
Right.
but it is curable, and it can be prevented by coming in and having the polyps removed.
And what's your scheduling time? Like what? Like
We're pretty quick, less than 2 weeks.
that's great.
So we have capacity to do any routine screenings we can get within 2 weeks, and any patient that's having an actual issue, symptoms, concerns, and we make it a diagnostic, we can get them in within 48 hours.
Wow, that's amazing. Because I would imagine that in other locations, probably that's not the case.
It is not the case. Weeks to months sometimes.
I keep every time y'all come on the show, I keep emphasizing to the public, your turnaround time is so much better, and the care is pretty much equally as good or better because it's a lot more personal.
Definitely a lot more personable.
Yeah. So I know that every year Springfield does an annual campaign, and this year the campaign funds are going to go to endoscopy. So what is it that you would be adding, or what if people were inclined to want to give to the annual campaign, give a real life scenario of what the money's going to go to?
We were fortunate. They did choose the endoscopy suite, which we're really excited about. We are looking to purchase a drying cabinet at a lot of places, almost all of them. You have a drying cabinet, and it's the place that you hang your scopes after they're cleaned. They go through a manual cleaning process, and then they go through our Medivator, which is a high-level disinfectant. And then we dry them manually on the counter. The correct process is to put them into a airtight, forced medical grade air, and it circulates through the cabinet, and it just keeps them dry. It's not a cleaning of any kind, but it just really dries them from the inside and the outside. What we're looking to not have is any leftover wetness inside the scope, that it sits there and then it begins to grow bugs that we don't want in there. So the drying cabinet is something we're very excited about. We've been trying for a few years. So we are hopeful that we'll be able to get that pretty soon. Be great.
It'd be great.
No, so there's a reason to give to the annual campaign this year. And you can just go right onto the Springfield Hospital website, and I bet there's a donate button. I haven't looked, but I'm guessing there probably is a
Not
donate
certain,
button.
but if not,
It's
Bill,
not that
make sure
hard.
that happens.
Yeah. Tell me what the infusion clinic is. I'm intrigued by that.
It's another great little department. The infusion clinic has been around for many years. It's staffed by a great team. One of our nurses has been there for a long time, greater than 10 years. We get referrals from either inside the hospital or from local doctors' offices, and we'll do anything from therapeutic phlebotomies to iron infusions, hydration. We will do IV antibiotics. We do PICC line dressing changes. We will access Mediports. They have to be accessed usually at least monthly, if not more frequent. And so patients will come in, we'll do that for them, make sure it's still patent. We do labs, a lot of stuff. And we're very fortunate there that we have a lot of the same clientele. So that team really builds relationships with the patients. We used to do a lot of chemo. We don't, unfortunately, do a lot of that. We don't have a provider in-house for that department, so it's a little lacking, but we're looking at hopefully growing someday and adding on. But they're open Monday through Thursday, about 8 to 4:30.
It's good to know.
Great team. We're making some changes there to make it a little bit smoother for patients. We're registering patients now in the infusion suite. Instead of them having to come in, go to registration, then come back over, they can come right to us. We get them right in. We have 2 private rooms and then 4 chairs out in our common area.
Nice.
And even the patients get to know each other. We have some that are pretty routine, and so they come the same day almost every week or every other week. And they've built relationships with the other patients. They all talk, ask how their holidays were, what their summers are going to look like, that kind of stuff.
Again, the beauty of small town hospitals.
It is very nice.
Which is super important. And it's important that we all understand the beauty of small town hospitals so that we can do everything we can to make sure they stay small town hospitals.
Absolutely.
So talk to me a little bit about what would you need an endoscopy for? Like, what does that diagnose?
People that have a lot of GERD symptoms, heartburn symptoms, can tend to get changes in their esophagus called Barrett's esophagus, which is changing in the tissue when the esophagus tissue changes from normal stomach tissue to more or less colon-type tissue. And if that's not addressed or treated, that could potentially turn into esophageal cancer. Okay. So anybody who has like a lot of heartburn should have an EGD done to take a look and have biopsies done. And we do it for people who have abdominal pain, just to make sure there's nothing going on in their stomach, because there's other bacteria that grow, that you have in your system anyway, but can grow rampant, like it's called H. pylori, which is a bacterial that if that gets going or is out of whack, then it can cause issues too with patients. Sometimes when people take medications without food, they can get little ulcers and things that we can go in and we can take care of, either by cauterizing it or just making sure it's not bleeding, because we can clamp it with little clips. And with Dr. Lewis, who's now is trying to do Nissens, he can take a look, and people who have like big hiatal hernias, which is where part of your stomach comes up above your diaphragm, they can do a surgery to bring that back down to where it's supposed to be, which can help with your heartburn symptoms.
I was just going to say
too.
that's one of the can be a factor in heartburn, right?
Yes. The hiatal hernias.
And so that procedure. Talk me through that one. Well, no, I mean just there's no prep, right? You just show up.
No,
So-
you just NPO.
Okay.
You don't nothing by mouth for a minimum of liquids, a minimum of 2 hours, but nothing solid for 12. And basically that's they just come in that morning or that there's time, and they come in, they get ready, and we go down. It takes like 10 minutes to do the procedure. Half hour, we're done, and they're almost ready to go home.
It's mildly scarier to me than the other end. I don't know why. I know probably most people are like, no, I don't want the other end, because I just the whole. But very important because if you leave heartburn untreated, like you said, esophageal cancer, and I believe that's a lot less treatable than some cancers.
I'm not 100% sure on that one. I just know that
I just think it's worse. It's a worse cancer
would be worse,
because
and
if you're trying to radiate that area. Oh my goodness.
Yeah.
We are, believe it or not, we are down to 1 minute. I told y'all it would go slow, or go fast. So how they again just reiterate to the public how to get an appointment. So what is this? What are the procedures to get an appointment?
There's probably two ways they can do it. One is going through their primary care provider and having them refer them to the general surgery office. If they have had one done in the past and they're just going to be coming back for a follow-up, they can probably call general surgery and have it scheduled right through them. But the best place to go through their primary care provider.
And the number for general surgery is at 802-885-5600?
Yes.
Perfect. Okay. Awesome. So I highly recommend if you need either of those procedures, come see these ladies. They'll take care of you. And I thank you both for coming on. I learned a lot. I hope the audience did too. And we'll see you next week. Bye, community.